Good afternoon and welcome to our webinar, The Impact of AI on the Future of Sleep Technology. I want to thank you all for taking time out of your busy schedules to be with us today. My name is Rachel Bohr and I'm EnsoData's Senior Marketing Director. All right, and now I'm going to introduce everyone to Fred Turkington. He is EnsoData's SVP of Product Management, and he leads the team of development of new products and enhancements of current products for EnsoData. During the past decade, Fred has worked alongside hospitals, sleep labs, and DMEs to design workflows and improve the software that clinicians rely on to deliver efficient and comprehensive patient care. With a background in clinical customer service, technical support, and biochemistry, Fred bridges the gap between clinical needs and engineering. His #1 principle for making software in healthcare is empathy. And Fred lives in Madison, Wisconsin with his partner and very fluffy Newfoundland dog. And now I'm going to pass it over to Fred.
Thanks, Rachel. So my goal for today is to help teach you a little bit about what artificial intelligence is, why you shouldn't be afraid of it, and why there is good reason for optimism of AI in general, but specifically in the sleep world and in sleep technology. Our learning objectives for the credit for today are to understand artificial intelligence and machine learning, discuss things that AI is doing in sleep right now, as well as where we forecast AI will go in sleep, and to define new ways that the sleep technologist role can take advantage of artificial intelligence. I want to introduce you to the automaton. The automaton was a completely mechanical chess player built in 1763. It could beat people of above average skill at chess, and it was this marvel of a machine, went on this touring of Western Europe. And it was one of the first examples of artificial intelligence, which we can explain as a simulation of human intelligence by a machine. But to know if we're simulating intelligence, we need to know what intelligence is in the first place. It's perceiving or inferring information, retaining it as knowledge, and then applying it in new situations. So the automaton could see the chessboard, it could perceive the changes in the board, retain things that it had learned, and apply that as knowledge again, way back in 1763. And artificial intelligence looks intelligent, but it's really a simulation of human intelligence. And indeed, so was the automaton. Behind this mechanical contraption, there was actually a person hidden in the cupboard who was moving the chess pieces. And while the automaton wasn't actual artificial intelligence, AI has been around for quite a long time. The first artificial intelligence computer that behaved the way that human brains perceive information about the world was first built in 1968. That was before transistors were commonly used, when the back of your computer looked like this rat's nest of wires. And this first artificial intelligence computer was called the perceptron, also called an artificial neuron. And perceptrons are still the building blocks of the artificial intelligence networks that we use today in the state of the art in AI. So it really does go back all the way to 1968. But if AI is very old, why does it feel like we just started hearing about it? Well, two big things happened in the last 10 years that have made realizing the power of AI much easier to do. In 1968, before transistors were commonplace, you couldn't move data to where it needed to be together to be processed. But now, thanks to the power of the internet and high bandwidth network connections, it's easy to get all of the data into one spot for machines to learn from that data. And it required a lot of computing power. Computers just weren't all that powerful in the past. But as the price of manufacturing chips has come down and their power gets greater, those two things, computing power and data, have come together to finally make it feasible to use things like the perceptron to have real applicable outcomes for the world. So that's a little background on how artificial intelligence came to be. I want to tell a personal story now about why I got interested in AI. I was working in electronic medical records, working for a big EMR company that many of you probably use day to day in your sleep care work, documenting notes, vital signs, scheduling appointments for patients. I saw so much information being entered into these patients' charts that never got looked at again. It was hard to find, and nobody had the time to go dig up that information and make clinical judgments based on it. And I knew that if we were going to take care of all the patients that we need to take care of, we needed a way to help those people care for more patients. And computers are a great thing to scale each clinician's power of care. But as we saw on this poll, at least 15% of you are still scared about AI. When you think of it, the first thing that comes to mind is this image of HAL 9000 closing HAL out of the spaceship to die off alone in space. But I'm here to tell you that the future is not going to look like HAL 9000. So let's demystify AI for you to help make it a little less scary. When you hear AI reported in the news, reported in the media, I want you to start thinking of this new definition. Start calling it machine learning, because that's what's actually happening under the hood most of the time. And machine learning is just a different style of computer program that relies on probability and can take advantage of feedback loops. Pull the curtain back, that's really all AI is. It's a different way to program a computer. But it's a different way to program a computer for a specific task. In traditional programming, we write rules. Somebody gives a specification to a software developer, and they can write these if, then, else statements. It relies on stark lines of what is true and what is wrong about your representation of a problem in the world. And when the programmer writes it, they write it once, and then it's out there in exactly the state that it was made by that programmer. Until a programmer comes back in and makes intentional changes to the program, it can only ever do what it was first programmed to do. Machine learning, on the other hand, is really good at dealing with problems that have nuance or uncertain rules. There's not a great definition of what the correct answer is. You can be 98% correct or 95% correct and still do a good job. It's not so important that you get it perfect or wrong, the way that you might see in a traditional computer program. And this allows machine learning to take advantage of looking at its own output, seeing how good it did at solving a particular problem, if it got 97% correct, and retaining that information to do better the next time. So when I think of great examples of these two kinds of problems, with traditional programming, something like banking or a spreadsheet is a great application of traditional programming. The numbers need to sum up to what their actual sum is. If you add 1,000 and 1,000, getting 1,970 isn't close enough, it's just wrong. Versus something like weather prediction. If it's a 40% chance of rain, I'm still going to bring my rain jacket, even if yesterday was a 38% chance of rain predicted. Another analogy that I like to use about how you might apply this kind of optimization in your everyday life is with an SLR camera. It'll take that perfect crisp photo in exactly the right lighting conditions. But you're carrying around a camera case, special flash extra lenses, compared to the camera that's in your phone, which is easy to use, it's right there in your pocket with you, and it will snap a pretty good picture with low effort. And I bet most of you take the pictures that you take in your life with something that gets it mostly right most of the time and is easy to use, compared to something that gets it perfect every time but requires you to carry all of this extra gear. Let's go a layer deeper into how machine learning works. With traditional rules-based programming, you start off with data and you have a programmer apply a set of rules. You put it through the program and out come answers. Machine learning programming flips that paradigm on its head. You give your machine learning model the answers and the data, and you say, hey, this data produced these answers. Please figure out the relationships between the data and the answers so that you can come up with the rules. So back to our favorite analogy, if we have the sum function as the rule and 20 and 30 as the data, we feed those into our spreadsheet program and we get 50. A good analogy in machine learning is something like giving the machine learning model RPSGT, excuse the extra S there, scoring and staging on a sleep study, and the waveform signals that were recorded on that study, and tell the machine learning model to learn the relationships between the signals and the events that the RPSGT marked, learn the rules of sleep scoring. Now, the really powerful thing about machine learning is that it can incorporate its wrong answers to do better next time. So we start in this top left corner with the answers and the data that output the rules of machine learning. That process is called training. We took studies that were already scored by an RPSGT and their signals and came up with a set of rules. Now it's time to hypothesize how good are those rules. We'll feed it some new data, some new signals, and make a prediction about what the answer should be. Make a prediction about what the RPSGT staging and scoring would have been. But now you can check your guess. And how off you were from the right answer will now be reincorporated into the program so it gets better every time without a human having to intervene. And that's the really cool thing about machine learning programming. So to summarize, if you have the kind of problem that uses probability, it has nuance, the rules aren't 100% certain, they're maybe a little bit fuzzy, and traditional programming didn't solve that problem very well, and there's lots of data and it can all be brought together, then machine learning is a great solution for solving that problem. And so sleep scoring is only one place that we see machine learning being used in sleep today. We also see it being used in CPAP adherence and in AI-powered mask fitting. And the arrival of machine learning to sleep care couldn't come at a better time. We have a dire need around sleep care here in the US. We know that there's 23 million undiagnosed obstructive sleep apnea patients. And not only is sleep apnea extremely prevalent, but it's getting more common, with a 28% increase in its prevalence from 1994 through 2010. And even after we diagnose those millions of sleep apnea patients, only 60% of them will stay on their treatment long term. And to take care of all of these patients, we have a 43,000 to 1 patient to sleep physician ratio. But even though there aren't that many physicians, surely there's some RPSGTs to help, right? We minted 496 new ones last year, but this spring we found 964 open sleep tech jobs posted on Indeed. And while there were 17,000 RPSGTs in the year 2016, there's now only 16,700. We've actually reduced the number of RPSGTs in the field despite this increasing incidence of patients that need our care. So what I want you to take away from this, scary numbers, is if we are going to address the increase in disordered sleep with the same or fewer number of clinicians, then each of our caregivers needs to become superpowered to be able to care for more patients. Now, that might be a little bit doom and gloomy, but why is there cause for celebration or optimism? Well, in surveying the world of the workforce and artificial intelligence, Gartner expects that 2.3 million new jobs will be created because of the invention of artificial intelligence algorithms. And 74% of people say that they are ready to learn new skills or retrain to remain employable as the world changes around them. That's on the labor side of using AI at work. On the business side of using AI at work, almost all business people do not intend to replace staff with AI. Overwhelmingly, what they want AI to do for them in their workplaces is to support the humans doing their work and to do additional work off on its own. So you learned a little bit about artificial intelligence, why you shouldn't be scared of it because it's just a different way of programming a computer, why sleep is uniquely good for that kind of programming because of the fuzzy and uncertain rules. And we've seen this big problem in sleep care with a shrinking pool of clinicians and an increasing pool of patients to care for. So where does that leave you as a tech? I'm going to talk a bit about the advanced certification you can get, the certification in clinical sleep health, the CCSH. This will teach you additional skills for coordinating and managing patient care, aiming at outcomes of sleep care, becoming better at education for patients and for their community, and to additionally advocate for good sleep. And I think the CCSH is a great way to help you at your organizations go from the mindset of resistance, this can't work, this is scary, this might take my job, to a facilitator of change. AI is necessary to help us care for more patients. We'll be able to care for more patients and bring more revenue to our systems because we're using AI. And the CCSH will give you the tools to help with influence and organizational change. Having the CCSH, and even before you've got the CCSH, is going to lead to additional roles for the sleep technologist in the future. And those roles will be powered by AI. So for the rest of my presentation, I'd like to talk about the future of artificial intelligence in sleep, powered by these new roles for sleep technologists, and where I think we might see sleep techs and AI partnering to do that supercharged care of more patients. So first, the sleep navigator role, joining up with AI screening. The future of AI in this area is helping catch patients who are likely OSA patients in the course of their other clinical care. And it only starts with OSA. There's plenty of surface area of other sleep disorders that we can screen for. I'll talk about a paper that we wrote a couple of years ago. We looked at the stop bang evaluation, which many of you likely use in your clinical care today. The stop bang measures 8 variables, 4 observed variables or reported by the patient. That's if they snore, if they're tired during the day, if somebody has seen them stop breathing at night, and their blood pressure measurement, as well as 4 physical parameters, their BMI, age, neck circumference, and gender. And it's a pretty simple algorithm. You see yes or no, they have these issues, and you add them up and give them a score out of 8. And if you use stop bang to look at a patient population and predict, did this stop bang accurately guess whether that patient actually has sleep apnea? It does okay. There's this measurement that we use in statistics called the area under the curve, or the AUC. A random guess has an AUC of 50%, and a perfect guess has 100%. So you're kind of thinking, evaluating this number between 50 and 100 to know how good this is as a measure of predicting. And stop bang has an area under the curve of about 67. So it's better than random, but it's certainly not perfect. So what we did was develop an AI screening model. It used a bunch of parameters from EMR data to try and predict whether the patient was going to have OSA. And the area under the curve of the AI screener increased up to 75%. Now you may feel, okay, 75% still far from perfect, and you're right. But the other very useful thing here is that this is an entirely passive screening. In the stop bang, you need to ask 4 questions of patients. We've talked to sleep navigators who are very keen to start an inpatient sleep navigator program. They want to get that list of inpatients to help see which patients they should go visit and educate them about the risks of sleep disorders. And they go to their nursing leadership and say, hey, I only need you to implement these 4 questions during intake, and are hit with complete walls of process. Every additional question needs extra levels of input from nursing, from admission, etc. And you don't get these questions asked of your inpatients. But using AI screening, you can do it entirely passively, using data that's already being collected in the course of a patient's care, from primary care through inpatient admission through surgery. And what we saw was the most important variables were the 4 bang parameters in stop bang. That's BMI, age, neck circumference, and gender, as well as the blood pressure, which is one of the reported values. But there's an interesting tail of predictors in the EMR. HDL, triglycerides, systolic BP alone without the overall BP, presence of diabetes, hypertension, or depression are all predictors of obstructive sleep apnea. And unlike stop bang, where you're merely adding up a sum to get to the number, the AI model can assign different weights to different variables to fit accurately the population and their observed presence of sleep apnea. So in the future, a sleep navigator is going to use AI screening algorithms that work completely passively to queue up their list of patients who they should see in the inpatient setting. If you want to become a sleep navigator, that's oftentimes how you'll spend your time. Work with patients, work with their hospitalists, the rest of their healthcare team to find sleep disordered breathing patients and educate them while they're there in the hospital. Maybe even help them get a home sleep test run from their inpatient bed and get them set up on therapy. You're also the nexus of education of sleep for a population of clinicians that doesn't tend to think about sleep nearly as much as we all do. Educating physicians, educating nurses while you're there in the hospital, helping advise hospitals on their safety protocols around patients with sleep apnea. We know that creates risks for patients, especially those undergoing anesthesia or having ventilation. And you're that connection for the sleep care for that patient from their hospital stay to their primary care and with follow-up on treatment. Not only is it great for patients, but it's also profitable. Sauk Prairie Healthcare is located about 45 minutes that way from my house here in Wisconsin, and they implemented an inpatient screening program for their surgical patients. And then they went back and did a retrospective analysis. How did it work? Well, of about 4,000 surgical patients, 94% of them had a pre-op assessment where they asked questions like the stop bang questions about their likelihood of having sleep apnea. And of the 95% of patients, 75% went on to need the OSA protocol during their inpatient stay after surgery. You can see the OSA protocol here on the right of the slide. It's instructions for their care team on what to do to help avoid the risks associated with OSA for that patient in PACU and inpatient care. And of that group, nearly 30% needed to have a CPAP put on during their stay in the hospital. And this program cost Sauk Prairie $161,000. And yet in their first year, it brought an additional $378,000 in revenue, in addition to sleep testing and clinic visits for those patients who needed sleep care but were falling through the cracks. So it reduced the risk of the hospital, caught more OSA patients, and yielded revenue, a net gain of $217,000 for this one sleep navigator. Now, Sleep Navigator is one choice you might make about how you'll partner with AI in the field of sleep technology in the future. Another one could be to remain in the sleep lab, working with AI diagnostics and taking on a role of a sleep educator. So AI diagnostics have been in sleep for a while. One of the ways that AI is used in sleep is AI scoring of lab studies and home studies. That's what we do here at EnsoData. And the first FDA clearance of AI scoring in sleep was in 2017. So it's been in sleep medicine for 6 years. This was a question that we got from one of you in the audience before as well. Now, that's been around for 6 years, but new devices are coming out every year. The Type 4 home sleep test and PAT devices. There's now a new normal, a new expectation that you're not starting with an unscored study. You're starting with an AI scored study and maybe making modifications to your scoring before you make the report available to the patient. Another thing we've seen though, with the rise of type 4 studies, with HSATs during the pandemic shutdowns, for patients that went from HSAT to AutoPAP, was that compliance rates were atrocious. I've heard this from about 3 different hospitals with their associated DMEs. And that's because that patient did not have a good educational handoff. It was done completely remotely. The patient was maybe a little bit unsure about being on this chronic treatment for this problem. And so you have this perfect opportunity. You've got your staff in the lab during the day, AI scoring to help relieve some of the burden of time that they have to spend scoring, and the patient there for their follow-up or for returning their device, which is a golden opportunity for these in-lab day staff to help intervene at that critical moment where the patient is going to decide whether they will remain on treatment. So the sleep educator role works in the outpatient setting to help patients with sleep apnea treatment. There's a sleep educator here at Northwestern Medicine in Northern Illinois, where their hospital-associated DME has PAP compliance rates of 87%, which just blows out of the water the sort of standard average across DMEs that is right around 70%. And they are able to take staff from their lab and use them to do education and setup with patients immediately after they receive their results. And the proof shows in this PAP compliance rate. Another way that you might be able to bring additional revenue to your system through this sleep educator role is with remote physiological monitoring and remote patient monitoring. These are 2 new-ish billable CPT codes that have been around for 4 or 5 years that allow you to get reimbursement for the time you spend remotely monitoring your patients on their treatment. There's remote patient monitoring, which is based on physiological data that is automatically transmitted, and remote therapy monitoring based on data from therapy that's reported by patients. These have to be reported by medical devices, and you can make a claim on either of these once per month for most payers with 16 days worth of data. And there's 4 CPT codes associated with RPM reimbursement. And I want to call out one in particular, the 99454 code. So this is the Medicare national payment amount for this year for that code. It's over $50. And what that code entails is the patient returning 16 days of physiological data to you for you to review. It doesn't require conversation or intervention with the patient, just requires monitoring the patient. So I think this is a really interesting way for sleep technologists to get involved with direct patient care, even when the patient's not physically in front of them, when you're monitoring them from afar to help intervene at the right moment and keep them on their therapy. Which brings us to the sleep coach role. We've done a couple of research papers in this area as well here at EnsoData. Last year, we published a paper for treatment prediction using artificial intelligence. We looked at this characteristic breath shape in the nasal cannula waveform called negative effort dependence. You can see the difference between A, the normal breathing waveform, to B, where you sort of see this hump shape dipped in the middle of the nasal cannula waveform that gets increasingly more severe as this negative effort dependence becomes more and more severe. And the presence of these NEDs in your nasal cannula waveform is highly correlated with future success with the Inspire or hypoglossal nerve stimulator device across 41 patients with our research partners at Northwell. And the current best practice for deciding whether a patient will become a future success on hypoglossal nerve stimulation is to give them an endoscopy under anesthesia. So using AI to look at some waveforms that you are already collecting anyway in a non-invasive way with the nasal cannula, I think is way preferable to having to put a patient under anesthesia with an endoscope to help discover whether they'll be successful on this HGNS treatment. So we can predict with some certainty future success on treatments, both from the physiologic waveforms, but also from the observing the data from those treatments themselves. We gave a presentation at Sleep this year, looking at 21,000 patients with millions of nights of CPAP usage data. And we showed that given only the first 7 days of CPAP data from that patient, you can predict if that patient will become compliant within 90 days, about half the time, compared to the naive or previous best usage models, which only get it right around 1 in 5 times. And that's with just 7 days worth of data. When you get to 14, 30 days additional amount of data, you can continue to give new predictions about their future adherence on CPAP. And that gives you a perfect opportunity to sort your patients by those who, if you reached out to them and helped intervene, you might get them to stay adherent on treatment. And that's what the role of the sleep coach is. Sleep, respiratory, and behavioral experts who can contact and guide patients with sleep disorders for their health and wellness goals. And it doesn't necessarily need to be disordered sleep only. General sleep health and wellness is another option for coaching. We've got friends who are coaches in executive and athlete success, where their performance depends a lot on their sleep. They don't have any sleep disorders, but they, like all of us, still need healthy sleep. And sleep coaching is a great opportunity to work remotely, especially if you are feeling burnt out of going physically into a lab or into a hospital. One type of sleep coaching, as I mentioned, is this adherence coaching, where you can use task-oriented approaches to looking at a population of patients, or these predictive adherence models that I had discussed. Your goal is to help them become adherent to CPAP. We work with 2 sleep coaches here at EnsoData who are teaching patients about the proper usage of their device, about how to properly clean it. They're communicating with the patient's sleep physicians when they observe problems that indicate changes to prescription, suggesting to those physicians, hey, you might want to increase this patient's set pressure. As well as coordinating with the DME, being that patient's inside expert on sleep with, hey, you need a different mask, I'm going to go help you get it. So in summary, there's these 3 new roles that you might be able to take advantage of as a technologist that are going to be powered by AI into the future. I love this quote from Dr. Horvath in the UK. He told pretty starkly to physicians, AI is not going to replace physicians, but the physicians who use AI are going to replace the ones that don't, which was reinforced last year at Sleep. AI is not going to replace you as a technologist, but the technologists who use AI are going to replace the ones who don't. And that's the end of my presentation, and I would love to take some time for questions. We've got at least 20 minutes left.
Thank you, Fred. That was a fantastic presentation. If anyone has questions, please make sure you get them in the chat. We did have a couple pop up during your presentation. The first one, I'm excited about these roles, but work in a large health system. How do you recommend getting a sleep navigation program started?
Well, first off, the RPT has lots of useful information to help you with that, so I'd encourage you to reach out to them. But I really think it comes back to showing what we showed in the example from Sauk Prairie, that this is not going to be a net cost to your health system. It is likely going to be a net benefit, not only in patient safety, in reducing risk, but also in increased revenue from testing and care.
That's great. We did get another question in, referencing more AI scoring itself. Does AI scoring learn from my scoring And what if it's maybe a poor score, or maybe a score that is having trouble?
Yeah, well, certainly different AI scoring models work differently, but the way that we have seen it be most successful here is to learn from a very large pool of scorers so that any individual scorer can't change the model too much, but that it does represent a very large sample of the way that scoring is actually done out there in the field. We see what's recommended in the ASM scoring guide, but there's lots of gray area in there. There's lots of discretion that is left up to the individual physician, the individual tech. And so there's a wide variety of practices about who stages what and who scores what respiratory event. So by combining everybody all together in one pool, you can get something that in this fuzzy machine learning world is 91, 92% of the way there. It doesn't have to be perfect. Remember, that's the thing that AI is so good at. It's getting it almost all the way there. And then you only need to change 8, 10% of the study. And it's going to save a massive amount of time, even though it's not exactly perfect.
It's a great explanation. Here's another one. Let's see here. Oh, and just there's been a couple requests for the slides. We actually do have this webinar being recorded, and we will send it out to everyone probably early next week. So you can watch for that. We'll send out an email with that information. Okay, what about AI scoring in pediatrics? Excuse me, is that as advanced as adult scoring yet?
In the research world, there is plenty of evidence to show that AI scoring for peds is also feasible. As far as I know, nobody has received FDA clearance to do AI scoring on pediatric patients, but really it's a matter of getting that data together and showing how good the models could be.
Okay, great. Let's see here. Did I understand correctly? AI can help predict appropriate masks, and if so, how?
Yes, that is a very interesting application. There's at least 3 mobile apps that I know of that are AI mask fit predictors. So what they do is they take a picture, a scan of your face, and they look at the profile of different bone structures in your face, and they have them correlated with a big archive of pictures of patients who have been successful with certain masks. And they use that picture of your face to help predict what the right mask is going to be. And we've seen this be a very interesting part of sleep coaching programs, especially during pandemic lockdowns when you couldn't be testing masks physically there with the patient, being able to use that to help get them the right mask the first time, not when they're 10 days into their window of 90 days to hit that compliance to get their machine paid for, get them started right off on the right foot with the proper mask. And actually, the other thing that we see is that a lot of DMEs, they have a standard protocol, right? They just give you the standard mask. Even from the get-go, there's a lot of opportunity to just start the patient off with a mask that's fit to them, that's not just your first go-to mask. So I think even that could help improve those 65, 70% compliance rates to well above the national average with just a slight change in the protocol used to give that patient their first mask.
Mm-hmm. That's a great. All right, let's see here. Lots of questions rolling in. How is AI predicting therapy adherence in advance?
So what we've done is we've assembled a data set of over 90 million nights of CPAP. So if you look at a patient who's on day 5 of their treatment, they've got their usage in a certain window. Maybe they put the machine on and wore their mask from 10 p.m. to 4 a.m. in one continuous session, and they have this age and this gender. And so we look at this data set of millions of patients, and we see all the patients that are similarly situated to them. Oh, hey, here are 1,000 other men in their 40s who used their CPAP on their first night from 10 p.m. to 4 a.m. What happened in their trajectory? When they used the CPAP or didn't use it for the next 90 days, what happened? And the more data you get, the more CPAP nights you get, the more likely your prediction of how that patient's journey is going to go matches the other patients in the data set that are similar to them. I think that's maybe the easiest way to explain it.
Mhm.
We can go down another level deeper, but think of it as we've seen a lot of patients go on the same journey, and that's how we can predict how this patient is going to go.
Yes. All right, we have an RPM question. Don't most payers allow only one RPM payment? So if the RPSGT is using it, does that preclude, say, PCP from monitoring blood pressure? How would the choice be made?
Yes, that is true, that most payers will only allow one provider to do that RPM claim each month. And I can't actually say who wins in that case. I think that's probably up to the individual payer and probably some matter of timing and documentation about who submits their claim first and a couple other things like that. So it likely varies by payer. However, you can look in Medicare, they release their claims in a de-identified data set for the past year. So it's millions and millions of rows in a spreadsheet of where all these claims came from all around the country, what physicians build those, things like that. RPM is very, very underused. The amount of patients who don't have any RPM claims on them is really high. So I think if you started an RPM program, it's very likely that nobody else is trying to build that RPM code based on what we've seen from the Medicare data. So to the
Here's
answer of your question, I would encourage you to go ahead and try it because I don't think there's going to be too much competition for that payment from their payer.
All right, here's a question about our sleep coaches. What kind of compliance improvements are you seeing with your sleep coaches involved in initiating therapy?
So we have seen an increase between 5 and 10% from the baseline compliance by the DME month over month. And you can think about the improvement that sleep coaches bring in two ways. One is getting that base compliance number up, right? That's 5 to 10% from the baseline by adding the coaching in. But then there's also this question of efficiency. So if you kept the same exact compliance, but did so with fewer mask changes, fewer, less waste at your DME, fewer trips back and forth for the patient that your staff have to handle interacting with that patient. If you get it right the first time, even with the same compliance number, coaching can help you be more efficient. But like I said, we have seen compliance increase 5 to 10% by adding coaches.
All right. Here's kind of a neat question. So what area of AI excites you the most in terms of making a difference in the field of sleep medicine, be it in patient outcomes, access to care, or reducing cost?
It's a really good one. So honestly, to me, there are two, and I can't choose between them, so I'll just give them both, right? The first is in that number of undiagnosed patients. We know that access to testing is a huge barrier, at least in the United States, to making patients aware of their sleep disorders. And testing is getting smaller, more convenient, easier to do multiple nights. Before, we were limited by the number of physical beds in the lab and the number of physical people who are experts that could attend those patients. Now, with things like the Aura Ring, with things like type 4 testing, sleep testing is becoming more democratized. People can learn about their sleep disorders way more easily and at a way broader scale than ever before. So that's what excites me the most in terms of diagnosis. But I think there's an equally big opportunity in treatment. It's a chronic condition with a chronic treatment, the kind of things that the US health system is particularly bad at optimizing for, and that are kind of a chore for patients. They really don't like being on chronic therapy. My own dad is one of those CPAP non-users who tried it for a little while, hated it, sent it back, and still has severe sleep apnea untreated because he doesn't want to be on a chronic treatment. So I think that AI to predict treatment adherence to CPAP in the same vein of that paper I talked about predicting adherence to things like Inspire, if it's going to work for you, what if we knew just from the sleep test before we ever gave that patient a CPAP, hey, this patient is 80% likely to fail CPAP. CPAP is not a good treatment for this patient. Please don't waste 6 months and a bunch of money and time trying to get this patient to use CPAP. They, however, are immediately great candidates for an oral appliance or immediately a great candidate for a hypoglossal nerve stimulator. Help make the case to payers and the standard of care to skip the CPAP when it's inappropriate and make the CPAP work better when it is the right treatment.
That is exciting. Another great question. Are you applying AI to identify endotyping of sleep apnea?
Yes, actually, great follow-up because that was essentially the last 15 seconds of my previous answer. Yes, we are interested in research in that area, and I know lots of research is being done by academics in that area as well.
Thanks, Fred. All right, let me see. I just want to make sure we do have a couple more minutes, so I want to make sure I didn't miss anything. I think we answered some of these questions in your other questions. So, I don't think I asked this one. Do these models take into account sensor electrode misplacement?
Yes, they do. And that's actually one of the big advantages to a machine learning approach for a problem like this compared to a rules-based approach. Because if you had to write down the list of every single thing that matters in whether your staging is right or wrong, you'd never get a computer programmer who would be able to write down the number of possible ways in which the sensor could be misplaced and the number of possible, skull anatomies for EEG placement that it could be placed incorrectly. But if it's out there in the world, the machine learning model can see it and observe it. So if we have 2 million studies and 30,000 of those have bad M1 electrode placement, the model sees it, the model learns it. The model learns what the human scored through that bad electrode placement. And when it sees another study with bad electrode placement, it can make a strong guess at how it should be scored.
Thanks, Brad. That's a great explanation. All right, I think we're gonna end on a more of like a personal question for you, Fred. Harkening back to the second poll, I'm assuming you use AI in your personal life and at work. Any tools you are excited about outside of sleep, and how do you use AI tools in your work? Do you think maybe computer engineers will be replaced by computer engineers that use AI?
I love that last line because we're already seeing it. There's a tool that I use in my personal life. It's called Copilot. It's made by GitHub, which is a branch of Microsoft that focuses on computer programming. So I'm a hobbyist computer programmer. I don't program for EnsoData, so you don't have to worry about my code in your algorithms. But I use Copilot, and Copilot essentially, as you are typing out a page of code, will automatically fill in what it thinks you're trying to do. And I'm not too rose-colored glasses about it, but I would estimate that Copilot probably saves me 20 to 30% of all of the typing that I would otherwise have to do. It just intuits what I'm going to do in this program and fills it in. Sometimes it gets it wrong, I have to go correct it, but the point is that for $10 a month, it's saving me hours worth of typing. So yes, I do use AI tools in my personal life. Copilot is probably the best example that I use in programming. But I also really like some of the creative outlets for AI. I was recently doing a project where I needed a graphic design, and I used a tool called DALL-E, which is a generative image AI, where you type in a description of what you want the image to look like, and it will spit out 4 candidates, and you can sort of select from those candidates and refine to get a better image. And I'm no good at drawing, I'm no good at Photoshop, but DALL-E is, and I could describe what I wanted and give me exactly the image that I was looking for. Again, to like 97% accuracy, maybe there are some spots that I wouldn't want it, but for the image I was looking for, way better than me having to go take Photoshop classes and learn how to do it myself.
Yeah, that's a great. And I liked your example of like when you use the pilot, what was it called again? Pilot AI.
Co-pilot, yeah.
Co-pilot, thank you. How, you as an expert engineering, biochemistry engineering person, you have that expertise to then look at what it gave you and make whatever corrections you needed. And I think that's a good correlation to what we look at with sleep. And if you have any other questions about EnsoData, please feel free to check out our website or contact us at team@ensodata.com. We thank everyone so much for taking time out of your busy schedules to be with us today. Thank you, Fred, so much for your insight and the fantastic presentation. And just thankful to all of our sleep technologists and clinicians just for all of the important work that you're doing in sleep medicine to reach and treat these patients. So have a great day, and we'll see you at our next webinar.